Hello, everyone. Thank you for joining in for the conference. Hope all of you are doing fine during COVID-19 crisis. I am Dr. Amna Mohsin, currently working as stroke specialty doctor at Leicester Hospital, UK. Today, I'm going to present a case on Digeorge syndrome and immune thrombocytopenia purpura, which I came across while working as a medical registrar in Al Qasimi Hospital, UAE. My consultant, Dr. Mohsin Shaheen, helped me in the preparation and publication of this case report. So let's start the case presentation. So, Digeorge syndrome, DGS, also designated as 22q11.2 deletion syndrome, uh, consists of phenotypically similar disorders. It consists of microdeletion of chromosome 22 at a location known as 22q11.2, also termed as DGS critical region. Now, it occurs in about 1 in 4,000 to 1 in 7,000 births. Almost 90% of the occurrence is due to sporadic microdeletion of chromosome 22. Now, this syndrome consists of various features. It often includes congenital heart defects, cleft palate, frequent infections, developmental delay, learning disabilities, and hypocalcemia. Kidney problems, hearing deficits, and autoimmune disorders may also be associated with DGS. Patients with DGS develop the autoimmune disease at a rate higher than the general population. Now, autoimmunity can be attributed to defective T cell production in DGS. Tyson reviewed the occurrence of autoimmunity in a large cohort of pediatric patients and found out that cytopenia and hypothyroidism were the most common autoimmune conditions. Therefore, autoimmune disease in the Digeorge syndrome are mainly immune thrombocytopenia purpura, immune cytopenia, juvenile rheumatoid arthritis like polyarthritis, and Graves' disease. So here we present a case report of a boy who was diagnosed with DGS on birth and later on developed ITP. So case is that a 15 years old boy of Arab origin of healthy parents from non-consanguineous marriage was diagnosed to have DGS at birth. He had interrupted aortic arch type B with anomalous erosion of a right subclavian artery from descending aorta and ventricular septal defect. He had a repair of aortic arch and VSD at an age of 3 weeks at a tertiary hospital. He was diagnosed as DGS in this hospital at an age of 4 years. He had a transaortic reduction of discrete subaortic stenosis with a good outcome. So he has been following in the pediatric department and then in the medical department of this hospital. History of presenting illness, he presented to the emergency department on 21st April 2018 with a complaint of non-traumatic minimal nasal bleeding, followed by a small amount of upper lip bleeding of 1 day duration. Purpuric rash in the post-auricular area was noted by the mother. Another purpuric lesion was noted in the right upper limb region, which was not itchy or tender. So there was no recent history of nasal, oral, or auricular bleeding. Patient denied any history of fever or flu-like symptoms, and review of rest of symptoms was negative. So the past medical history comprises of history of frequent infections in childhood, past history of admission in December 2016 with thrombocytopenia. He was given platelet transfusions and then discharged. Pregnancy of the mother was uneventful without any complications. He was delivered by spontaneous vaginal delivery and birth weight was 3.4 kgs. At an age of 3 days, he was admitted in ICU in a state of shock. He improved on prostaglandin administration in addition to ventilation and inotropic support. He was then transferred to the pediatric cardiology department at an age of 9 days and eventually referred to NHS Trust Hospital for further intervention. So, family history. There is no significant family history of such similar condition, mental retardation, or epilepsy. However, one of his paternal cousins had a sudden cardiac arrest at an age of 20 years. Cause was unknown and he was healthy previously. His vaccination was up to date. Development. So he showed poor school performance. He was studying in a normal public school and required special assistance. He has left eye amblyopia and wears corrective eyeglasses. Milestones were normal according to the mother. Physical examination. So general examination included dysmorphic facial features, hypertelorism. There was small thrombosed clot on the right, on the upper right inner lip, purpuric non-blanching, non-tender rash in right post-auricular and right upper limb. His body mass index was 20. Cardiovascular examination revealed grade 2/6 systolic murmur at upper left sternal edge. Pulse was normal and of regular rhythm. Respiratory and gastrointestinal examination was normal. His vitals were stable. Now, review management. So, the blood results revealed severe thrombocytopenia of 7. WBCs were 3.75. Hemoglobin 14 grams per deciliter. PTT 35.8. INR 1.13. However, urea electrolytes, liver function test, parathyroid, thyroid hormones, calcium, magnesium, phosphorus, CRP, procalcitonin, ANA, CMV, and EBV IgM antibodies, they were all normal. So the peripheral blood film, now it showed macrothrombocytopenia, normal RBCs, and WBCs. His chest X-ray was normal. His abdominal and pelvic ultrasound was normal. The patient was admitted under the impression of possible immune thrombocytopenic purpura. He was started on immunoglobulin and prednisolone. During his stay in the hospital, there was no more bleeding or bruising. He responded to the therapy and his platelets improved. On discharge, his platelets were 132, WBC increased to 6.76, hemoglobin 13.9, INR 0.97. He was discharged on 40 milligram of prednisolone. He was referred to hematology department of a tertiary hospital where it was confirmed to be ITP, and he has been on steroids since then. His recent cardiac evaluation and echocardiography report on 26 March 2019 showed ejection fraction of 62%. It showed trivial mitral valve and tricuspid valve regurgitation, mild concentric LVH with normal systolic function. So, an overview of blood results from 2014 to 2019. His past blood results revealed thrombocytopenia from 2016 onwards. It also revealed frequent low total WBCs with low absolute neutrophil counts and seldom low lymphocyte count. So we'll come to the discussion of the case report now. So this is a case of Digeorge syndrome presenting with immune thrombocytopenic purpura which responded to steroids. All the past labs from 2016 onwards showed thrombocytopenia and fewer times showed low absolute neutrophil lymphocyte count and leukopenia. So the incidence of immune thrombocytopenic purpura in people with DGS is approximately 200 times more common than in the general population. Now, the higher incidence of autoimmune disease in Digeorge syndrome is partly due to the depressed expression of autoimmune regulator in the thymus. eventually leading to decreased negative selection of autoreactive T cells. So, the severity and prevalence of immune deficits present in DGS are highly variable, although complete thymic aplasia is rare. The immune deficiency found in children, it sometimes persists into adulthood, and in this patient, as we see, that low WBC can be due to frequent viral infections attributed to immunodeficiency itself. And secondly, low absolute lymphocyte count can be associated with thymic hyperplasia. So, thus, immune thrombocytopenia and other hematological abnormalities seen in Digeorge syndrome are due to genetic disorder itself. So, the conclusion is that a multidisciplinary approach is required for individuals with DGS. The primary physician also must monitor growth and development. A system by system approach results in the best outcome. For hypoparathyroidism associated hypocalcemia, calcium supplementation and vitamin D supplementation may be needed. Corrective surgeries for congenital cardiac anomalies, cleft palate, and for congenital anterior glottic webs, tracheotomy or surgical reconstruction. Regular monitoring of full blood counts to look out for cytopenias. Therapies for immunodeficiencies include thymus transplantation in case of rare complete Digeorge syndrome, to follow up regularly for any autoimmune complications in partial Digeorge syndrome. So this is the end of my case presentation. And these are the references of my case report used in my case report. Thank you so much. Thank you for listening. Hope you liked it.